Okay, I think we can start. All right, we'll go ahead. I'd like to, on behalf of Advancing Excellence in Long-Term Care Collaborative, welcome everybody to our Spotlight series on pressure injuries in post-acute and long-term care. I'm Barbara Bowers, Emerita Professor at the School of Nursing at the University of Wisconsin-Madison. Just a few housekeeping things before we get going. Please, if you have questions, we will be holding them until the end. Try to have enough time for questions. So please put your questions in the Q&A rather than the chat. For those questions that we don't get to, we will be printing out the questions sent in, and as a group, we will respond to them, and everyone who attended the session will be receiving a copy of the questions and the panel's responses to them. So for those we don't get to. If you've signed up for CEUs, you need to stay for the entire program in order to get an evaluation. So you'll be sent an evaluation after the program, and then you need to complete the survey that's sent along with that in order to get your CEU credits. So that's a bit of the housekeeping that we have. I don't think there's anything else. So it's my pleasure to present a panel today. I'm going to be moderating this, and I'm really delighted to have three experts in pressure injury prevention and management to join me. Our panel includes three people who have extensive experience in direct care, in long-term care settings, who have had management experiences extensively, and who've all been involved in the development and oversight of clinical care development programs. So let me introduce our panelists to you. Start with Susan Kelleher. Susan currently works as a consultant for Pathway Health. She is an RN and a certified wound care specialist. She has experience as a director of nursing and a director of clinical services, a long history of involvement in wound care prevention and management. And she currently, in her position, mentors a lot of DONs on the development of quality improvement programs, including pressure injuries. So welcome, Susan. Next, Jenna Heim. Jenna is a quality improvement consultant with Metastar, which is a member of the Superior Health QIO. Jenna is an RN, certified director of nursing services, and she has had multiple positions in quality improvement program development and process development and oversight. And she's currently a member of the CMS Quality Improvement Network. One of the interesting things about Jenna is she is currently directing a CMP-funded program on back to basics in skincare around the state of Wisconsin. I think it's all within Wisconsin. So welcome, Jenna. And then we have Fatima Naqvi. Fatima is a physician and geriatrician. She is an assistant professor at George Washington University in both palliative care, hospice care, and long-term care. And she has served as medical director in long-term care and hospice care settings. Many of you will be familiar with her work. She writes a monthly column for McKnight's on wound care. You've probably seen it. And she is past recipient of the Maryland Medical Director of the Year Award from the Mid-Atlantic Society of Post-Acute and Long-Term Care. So welcome, Fatima. Okay, that's our panelists. So let me begin with a brief update and some comments, just general comments about pressure injuries. Concern about pressure injuries is nothing new. If you look back at even really early historical documents on healthcare, there are mentions of pressure injuries. So the issue's been around and recognized for a very long time. Caregivers are all taught about pressure injury prevention, and I know built into work routines is a lot of work directed at preventing pressure injuries. We also have decades of really good clinical work and laboratory research on how to best assess pressure injuries, how to prevent them, what are the causes, and that really hasn't changed a lot over time, although we've made some progress in reducing the incidence of pressure injuries. But it continues to be a real challenge. So let me give you some recently reported statistics. The prevalence of pressure injuries has been established at between 11 and 12%. There's a lot of studies that have looked at this, and they all kind of land on the same number of post-acute and long-term care residents. So if you look at that in terms of the number of people currently living or spending time in long-term care settings, that adds up to about 150,000 people currently with pressure injuries. So we're talking about a lot of people. And although we don't generally think of pressure injuries as life-threatening conditions, about 60,000 people die annually of pressure injury related problems. So it certainly can be severe. The incidence of pressure injuries has not changed in a while. It's pretty much stabilized in both hospital and long-term care settings. But unfortunately, the severity has increased. So while we have the same number of people with pressure injuries, more and more of them are stage 3 and 4 instead of stages 1 and 2. So we still have work to do. There always has been and continues to be debates about, is every pressure injury preventable? And I don't think we're going to get into that particular debate, but good scientific evidence would suggest that about 95% of the pressure injuries we see are preventable, could have been prevented. So to sum it all up, we have not cracked this problem. We still have work to do. So what are we going to do here today? So with the help of our panelists, we're going to look at questions about what are we not doing right? What else can we do, particularly in terms of preventing the later stage pressure injuries? And really our purpose today is to look beyond the clinical care. We're not going to talk about the technical aspects of pressure injuries, either prevention or management. We're going to talk more about the systems around them, the systems created that allow good pressure injury care to continue, and some implications for leaders in long-term care settings. So not the clinical staff, but the leaders in long-term care and the systems that we've created. So I'm going to start by asking what might sound like kind of an odd question, and that is, why should we be so concerned about pressure injuries? Besides what we've already talked about, like what else is there to be concerned about? So let me start with Susan. I ask you a question about which we don't hear so much about, but what's it like to have a pressure injury? What happens to residents who experience pressure injuries? Why is this so important?
Thanks, Barbara. Well, it's terribly important to the person who is suffering from a pressure injury. There's suffering for that individual at multiple levels, none the least of which is pain. It's often underappreciated, it's often undertreated or not treated at all, especially with residents who have dementia. And there has been a myth that pressure injuries are not painful at higher stages, but of course we know that is not true and not current. A resident can experience chronic pain related to a pressure injury and have it impact every minute of their day. Or they can have incidental pain with just the dressing change, and that's not just pressure injuries, but all wounds. So medication management, either topical, oral, or both, should be evaluated and should be part of that treatment order. And also, pain management should be assessed before, during, and after any dressing change is completed. If that person is positive for pain during a dressing change, verbal or nonverbal symptoms, we have to stop, treat, and reevaluate later. Leadership is responsible to ensure that pain is managed for those residents who have wounds. It has a big impact. The other impact that a pressure injury has is to that person's quality of life. As someone who has a pressure injury, again, pain, which also can prevent improvement of that pressure injury, but also a change in that person's normal routine, even something as simple as requiring offloading. Also, there can be an increase in anxiety related to isolation, or the anticipation of the dressing changes. That person may now be restricted from some activities or outings because of the treatment of the pressure injury. And it's not on purpose, but the facility time constraints or schedule may not coincide with the resident's usual routine. And that resident's choice, therefore, may be altered. The other quality of life issue is body image disturbance. We don't think about that, but the person who has a pressure injury may detect an odor, or they may feel they have an odor, and they may be isolating as a result of that. And also the focus becomes on that pressure area. And while oftentimes those pressure areas are in a private part of the body that people are not necessarily used to us, going in and staring at all the time. And that resident then is now seen when we come in as their wound and not so much as the resident themselves. Also, that person's independence has suddenly become altered. There may be new people that are involved in their care all of a sudden that they don't know, and they're looking at parts of them that they feel uncomfortable about. There's going to be new equipment, likely a new bed, a new mattress, a new wheelchair, different products that are introduced into their life. There may probably be a change in their diet. They may or may not have as many options in their diet. They may have additional foods and supplements and that type of thing. And also, there can be some shame related to having a pressure injury, maybe not specifically, but sort of implied that because they didn't offload or they didn't do this or they didn't do that, that they're contributed to their medical condition. And then that can impact their social interactions. So pressure injuries really impact every aspect of the resident's life, not just the injury itself.
Thank you, Susan. If I can chime in, you're so right on that. Like, I feel oftentimes patients are so embarrassed to talk about where, the areas where they're hurting. And unless we are more proactive as a provider, we don't ask them, they won't tell us. And then the guilt part, and it may not be just a wound, they be carrying some other kind of guilt, and now that they have a wound, so that gets exacerbated. So thank you so much for what you shared.
You're welcome.
It's certainly good to remember that this is not just a wound and a clinical issue. It is a fundamental quality of life issue for residents. I think it's interesting that a lot of the myth about no pain, especially with advanced late stage pressure injuries, came from the fact that most of the early research was done with people who had spinal cord injuries who didn't experience pain. And that myth has just persisted. And I was amazed to see the number of people from recent surveys who still believe that there is no pain associated with pressure injuries, or it's just minimal. So thank you for that. Jenna, talk to us a little bit about what are the implications for staff, for resources, for time, and emotional impact on staff caring for people with pressure injuries.
Sure. There's a significant impact for sure on time and resources. If we consider the nurses in skilled nursing facilities, their time is already stretched really pretty thin. And having to provide care for a resident or a patient with a wound, it's going to take time to not only prepare for the dressing change, but going in to do the dressing changes. If there requires extra staff assistance, that's all the time being pulled away from their ability to care for other residents. In addition to, it can get costly. So the resources associated with wound care then is also an issue on the staff resources.
Great. And Fatima, can you talk to us a bit about the actual dollar cost of pressure injuries?
Yes. And that's one thing. And even the other thing I was thinking about was, one is to change the dressing and all that. The second is, do they really know how to do that changes and the dressing changes? Have they been taught and trained? And did they ever experienced doing it for a patient before they're doing it on their actual patient? And the cost, oh my gosh, is the cost of time and the cost of money. So usually the cost of pressure injury per patient can range from anywhere from $20 to $150 per patient. And if you do the annual cost, it goes down almost around $3.3 billion. And it's just not a very small number. Per patient, you may think $20 to $150 per patient is what you cost, but $3.3 billion is really a bigger number that we all need to sit and think about what we are doing and where we are going.
Yeah, I think actually it was, I know you misspoke there, $20,000 to $150,000 for the cost of a pressure injury. So,
oh my gosh.
yeah, it is
Yeah.
substantial. Yes. Also, there's the cost of liability. In particular,
Yes.
pressure injuries at stage 4 generate, last year, I think there were over 17,000 lawsuits. So not insignificant. And also it's a huge impact on the family.
Yeah, sure. And I can actually share some of these statistics on that. So it's really rampant. It's not that one state has more lawsuits than the other state. But interestingly, the pressure injury lawsuits really end up costing more than any other lawsuits.
Mm-hmm.
Like I can tell you in Maryland, I live in Maryland. So in Maryland in 2023, there was this 64-year-old man. He was recovering in a post-acute long-term care after a stroke. And then he developed bed sore and he died. So we don't know why he died, what was the case, but the family took the case because he died because of the pressure sore, and they ended up winning, and he got $9 million. The family got 9. Pennsylvania, same thing happened, had a dysphagia, and 240,000, as much as $30 million has been actually jury awarded that to the family in California who was admitted to post-acute long-term care after a hip surgery but developed a wound which ended up causing more damages, and that was the cost that jury had to give to the family, $30 million.
Yeah.
So prevention is always better than cure.
Yeah, and I think it's important to point out that this is something that families get incredibly upset about, see it as something that could have been preventable, and evidence that staff has not done a good job or not cared. So it was interesting. I was reading a study recently. It's the only one I've seen that addresses this question. They did a comparison, unfortunately in a hospital setting, not long-term care, but they did a comparison between the cost of implementing a rigorous pressure injury prevention program and the cost of managing and all the things that happen as a result of pressure injury development. And it found that even though there is clearly some cost to implementing the program, that the cost of after the pressure injury develops is much, much greater. So an upfront investment for some good results later. Let me shift a little bit. Susan, if you could talk about, we'll say for a moment that sort of entered this side of the debate, that some pressure injuries are actually not preventable. So what happens with an organization, or what advice do you have for an organization that has done everything they can think of, has really done, they think, a good assessment, a good implementation, followed through well in pressure injury prevention, and somebody develops a stage 2 or 3 pressure injury? What can an organization do to protect itself in terms of both the family, the surveyors, to say, gee, it wasn't our fault?
Right. Well, there's a lot of discussion, of course, about how we can document that a pressure injury of any type was unavoidable. And frequently, when I go into a building, I'll speak to staff and to try to determine if there was an unavoidability with that pressure injury. Documentation is really critical. And it begins with a truly comprehensive assessment. And we begin with a Braden scale, but a Braden scale is just not enough. If we have a full picture of our post-acute care residents, we know now, of course, and certainly during COVID, post-COVID, that we have some pretty fragile and sick people living in long-term care. What we are not finding when we review documentation and assessments is a full head-to-toe evaluation of all the risk factors that could contribute to that person developing some type of alteration in skin integrity. If you think head to toe, top to bottom, you want to have in that medical record everything documented that could be a contributing factor. Behaviors, diet, dietary compliance, communication ability, pain management, medications, medication side effects. And then as we go down the body, we think about cardiac status, respiratory status. We have to consider, absorption, nutrition. We have to think about elimination. So we have to think about continence and their awareness of incontinence. And then we go further and we have to think about perfusion to the lower extremities. Oftentimes we have pressure injuries that develop on the lower extremities, or are they not pressure injuries? And we have no history or information about that person, but they have a diagnosis in the chart that says PVD, but we've not taken that into consideration when we go to develop our plan of care or further investigate it. So considering that whole person, and for a lack of a better way of saying it, we want to paint the picture that this person is really a train wreck about to happen, right? And then once we identify all of the risk factors and we have a truly clear picture, those risk factors need to be documented as addressed on our care plan. Somewhere within that care plan should be addressed those risk factors that we're finding and identifying. And then we should have an IDT summary, especially for those people that we identify as really being at high risk. Our physicians, our medical directors, they too should be reviewing that risk assessment that possibly nursing has completed, and they should document within their notes a collaborative statement stating that this person has unmodifiable risk factors that and considered to be at very high risk for pressure injury formation due to those unmodifiable risk factors.
And have you seen this documentation actually work for people with a pressure injury, and the surveyor saying, well, looks like you've done what you can? Does it work?
I think if we have everything in place, and we actually take credit for the work that we're doing. It's not that we're trying to create an excuse. The fact is that there are many unmodifiable factors in a lot of our residents. As long as we have identified those and we've translated those over to a real action-centered, person-centered care plan, it's important to do so. And especially after there's been a facility-acquired pressure injury, a root cause analysis needs to be completed, and we need to really dig into what happened and was this avoidable? Was it unavoidable? And if it was avoidable, where did our system go wrong? And then we take a QAPI approach to that and really look at it with that QAPI mentality. Almost always a systems issue. It's very rarely a person issue.
So I know you've been involved in post-survey remediation related to pressure injuries. Anything to add in terms of helping people who've been in that situation?
Yeah, certainly when we have a facility citation that can be a high scope and severity, it can be immediate jeopardy, it can be a directed plan of correction. All of those, we would take the same approach, and that is a QAPI approach. We need to look at the surveyor's findings, and we need to really drill down as to where our system failed. Like I said, it's very rare that we have a person-centered issue. It's almost always a system-centered issue. The root cause analysis needs to be conducted as part of that survey remediation. It needs to be real. It needs to be valid, and it needs to involve team members on all different levels. And if we have a mandated plan of correction, it's going to require this anyway. So we need to make sure that it counts, right? And it's accurate. We can pull the critical elements that the surveyors have used to evaluate our wound care prevention and management program, review our policies, procedures, and protocols, make sure they're current and up to date with not only regulations, but also with standards practice. And we want to look at all of our clinical systems because, as we know, all the clinical systems feed into wound management and wound prevention. So if our incontinence program has gone awry, we're not probably going to have skin issues as well. And then you want to review the residents. One of your first actions, and of course, these are not necessarily in order. Hopefully, a lot of these are taking place simultaneously. You want to start by making sure that your Braden scales and your resident assessments are current and up to date, and that your care plans are accurate, up to date, and make sure that they do have meaningful interventions based on your risk assessment. You'll want to be sure that you educate all staff on wound prevention and management program within the facility. There may be additional education needed when we evaluate our root cause analysis and develop our action plan from there. So some things may be specifically targeted for nursing, but this should be a facility concern. Everyone should be aware of what we do to prevent pressure injury development. And again, you want to dovetail your education of all those clinical systems if needed, if that's part of what your root cause analysis shows as a contributing factor to your system breakdown. And that includes all nursing staff, and it should also be included in your facility orientation, and it should be included in any education for your agency staff coming into the building. If you are currently cited, you need to make sure your agency staff are well aware and have signed off on all of your corrective actions. And your resident review, you want to begin with the residents who have active wounds and then go to the high risk residents. So once you've done your reevaluation of your residents, active wounds first, then high risk residents, and then all residents from there. And then after you've completed all of your actions within that action plan that's based on your root cause analysis, it's the end point there is supervision and auditing. And auditing should take place and supervision should be able to be done at all management levels. So charge nurse to director of activities, dietary manager. Management at all levels should be involved in auditing and supervision to make sure interventions are in place. And then those audits should be reviewed by the IDT team and a summary written and reflect back on that root cause analysis and your QAPI process and make sure that if there's any new actions that are needed, did we find a new problem while we were auditing? Was there something that we missed on our root cause analysis? And as a result of that, the follow-up actions that you take. So do you do new interventions? Do we need new equipment? Do we have new education that needs to take place? What is the result of our audits and what are we doing in response to that?
Complicated. You've just given us a really good overview of why it's better to prevent them than to have to deal with them afterwards. I mean, what you've just described is hugely time consuming. Yeah. Yeah, thank you. So let's move on to preventing the 95% of the pressure injuries that probably could have been prevented, that weren't such difficult high risk. whether you believe they can be prevented or not. Let's look at in a more general sense. Jenna, maybe I'm going to ask you this question. Where are we failing? What are we doing wrong? And maybe more importantly, what else should we be doing?
So for me, the top thing that comes to mind is the lack of interventions put in place associated with a lack of a accurate, timely, and most importantly, comprehensive assessment. So all of those pieces that Susan just talked about within that assessment need to be taken into consideration when we're selecting interventions to put in place to prevent pressure injuries. We can't just look at the number of our pressure injury tool that we're using, our skin risk assessment tool like the Norton or the Braden. We can't just look at that number. We've got to look at comorbidities, medications, things that also the residents' input is key to which interventions we should be putting into place. You know, a lot of times I've seen in a facility, they've got great protocols, but there needs to be an ability to really step outside the box and think about the person, like Susan mentioned, the whole person. So there can't really be a set of canned protocols to put in place. If a resident comes in with X, Y, and Z, we do A, B, and C. That's not really how it works. It needs to be an actual consideration of all of the factors that go into for one particular resident.
So let me put you on the spot a little bit. Do you think most staff understand all these things? Is it a matter of knowledge or the system around it, or both?
I guess in my opinion, whether they know this or not, a lot of times it's the other factors surrounding the nursing care in a skilled nursing facility. You know, like they may know that should be that further in-depth review of the medical records should be completed in order to determine those specific interventions. But do they have time to do that in-depth review? You know, do they have the support and the ability and the resources to do so?
Great. Yeah, something to look at in addition to do they all know and not just assuming that it's going to happen. Fatima, I'm going to ask you about technologies. There have been some new technologies on the market to help better identify pressure injuries and I think in particular deep tissue injuries at an earlier stage. What can you tell us about these technologies? Are they any good? Do they help?
Yeah,
Are they
sure.
cost-effective?
And I have been listening to you guys so intently and learning so much from you. Before I talk about technology, I do have just one more cent to add on to it. Was as a provider, you know, as a medical director or as a physician, as you're saying, it is maybe a system issue, but really reinforcing the knowledge as well as the system for early detection is so crucial. Checking on the skin early on within 24, 48 hours is so important because sometimes, and that's where I would take you to the technology, sometimes the wound start to happen even before you see the skin changes around the skin. And if you have seen the skin early on, you may not even own that wound because the wound is started early on in the hospital before the patient was discharged to the subacute facility. So, and that takes me to the other point, and the provider has to make sure they take the detailed history, the neuropathies, the spinal stenosis, the hip surgery, the immobility, because they all compound together to give the wounds if they were not there at the time of admission. And that take us to early detection because most of the time when you have a stage 1, there's a lot of damage that has already happened in the skin in terms of the cell damage, the tissue injury, be it stage 1, be it deep tissue injury. If you are finding the wounds at like stage 2 and 3, that means one needs to really be more proactive and find them early on because that's when you need to hit the target before it's stage 1. So now with the technology, we have identified there is a pre-ulcer stage, which is the cellular damage already happened. There is edema under the skin. There is swelling around the skin. The blood flow is decreased around that area where the pressure injury is going to happen. And we have two technologies. One of them is subepidermal moisture technology. We call them SIM technology, and it's very easy, handy to do. You take the instrument, you look around, you find the pressure, and it tells you that patient already has the skin damage based on the local edema, the focal cell damage, and this is actually FDA approved. So it's not even people are experiencing it. This technology is FDA approved technology, which can help us find the wound 5 days before you see the skin damage. So that's number one. Number two is another, which most of the hospitals I have seen have started to do, is the long wave infrared thermography device. So it's a device, and then you take pictures of the wound where it tells you how the circulation is, how the heat is, how the flow is, and that too pick up the wound 5 days before you develop a stage 1. So these instruments are reliable, and these instruments are pretty valid. Question is why we are not implementing them in our places where we can find them early on and even prevent the wound ulcers. Barbara, over to you.
So are they expensive?
And that's where the concern is, the cost. The cost of these instruments, the expertise. Even if you get it, I think the bigger problem is the providing the expertise. Who are gonna take ownership of these? Who is gonna do it early on? Who would maintain it? And who would follow through? So it's not just the cost that is an issue, because as you know, we may have a lot of wound experts around, but actually what is being done and what's being implemented than what is proposed may be two different worlds.
Right. So again, we're talking about the system around the technology that allows it to be used effectively.
That's correct. So hospitals have started using long wave infrared thermography, because sometimes when I see the patients, I see the pictures. But you see, the problem which I see there is they are looking at the wounds which are already there. So for us working in post-acute long-term care to prevent, we need to be more proactive and find them which are not there yet, which is a pre-ulcer stage. And staging has not really created this stage of pre-ulcer stage of the skin wound. So that is probably my dream, to pick it up as a pre-ulcer skin breakdown.
Right. That would certainly help us all out. I'm going to shift. Thank you very much, Fatima. That's actually really good information. We could probably do a whole session on figuring out when to use it and how to use it and how to create those systems, but good start. I want to shift a little bit to raise an issue that has actually been around. There's been some awareness, papers published on this for probably 15 years, but for some reason, this just hasn't found its way into routine practice. And that is the disparity in pressure injury incidence and prevalence between people with darker and lighter skin tones. I was sort of astounded to read about this, that actually there are twice as many pressure injuries in people with darker skin tones than people with lighter skin tones. And it's not just twice as many, it also has a much higher percentage of stage 3 and 4 pressure injuries. So this is a group, people with dark skin tones, in particular African Americans, who are at particularly high risk of having pressure injuries not identified until later. One of the most startling things I found was that the mortality rate for African Americans is 5 times that for people with light skin related to pressure injuries. So it's a huge disparity, something that we really need to look at. And from what I've seen, even talking to people who focus on wounds in their organization, there's the acknowledgement of that and the what needs to be addressed in order to take that into account has really not found its way into our usual practices. So, Susan, can you comment on what are we doing wrong? Why is this still an issue?
Well, I think the research and the translation of the research into practice just hasn't occurred, and we've not seen a real focus on it when it comes to standard of practice, enforcement of prevention programs. My experience most recently is that we have a high number of dark-skinned individuals in post-acute care with, again, a lot of comorbidities. But our nursing practice and nursing education hasn't reflected that change. I think it's a lack of awareness, and it's definitely a lack of education. It's not something that is in the mainstream education. Yeah. Although I'm seeing improvements, it's not mainstream at this point.
Yeah, and we've known about it for a good 15 years. So, interesting lag. Fatima, go ahead.
It's a burning topic.
Yeah, go ahead.
Close to my heart. So close to my heart. And thanks to you guys, Barbara. Thanks to you, Susan and Jenna, for enlightening this to me. And recently I have done with all of you a lot of work. Actually, there is a lot of healthcare disparity and inequity that is existing for the early detection of pressure injury. And the evidence, as you are suggesting, that they are finding that almost 50% of the time, stage 1 goes undetected, and stage 3, 4, and even deep tissue injury, you find it 50% of the time after or later you find this for other skin colors. So it's really the tip of the iceberg because the gap analysis that they have seen why it happens, and is it that patients are not telling you they're having pain, or is it you are not detecting? And that really leads to few other things, and I will just make it jot down 1, 2, 3 for the sake of our time too. So first is the way we do our objective skin assessment, how we say white color or black color, this color, Korean color, the way we are using our objectivity for skin assessment really needs to be modified. If I'm a medical director, I need to start that first, where there are skin assessment criteria that tell you what kind of color you would call it rather than cultural based description of the skin. The second gap analysis is really the way we have identified the wounds really needs to be reviewed, because deep tissue injury may not be a darker color in a darker skin. So that's where we need to find out really what are the other colors, what are the other changes, what are the pre-ulcer changes, what is the patient saying, and comparing one area of the skin to the normal area of the skin before you look at the wound. So again, these are the things that when I talk with my other colleagues and medical directors, we all really need to have a deeper dive and have an augmented visual technology, which is not just looking at the skin, but looking at other factors and incorporating these technologies to prevent even the wound from happening.
Yeah, thank you. Jenna, anything you want to add in terms of the actual assessment? Like, what about the tools that we're generally using? Are they going to work with people with dark skin? And what's the problem there?
Sure. So the one thing that comes to mind for me is the resource provided by NPI-AP on staging. I'm sure you've all seen it. We were taught it in nursing school, and it was in all of my wound care books in the facility I was working at as director of nursing. but the staging resource, the NPI-AP staging resource, actually was just updated to have a dark skin version in 2020. So the information has been out there, but we haven't really educated or taught this concept in nursing schools. When I went to nursing school, it wasn't taught for sure. And this resource coming out in 2020, it's alarming, but hopefully now that it's brought to the awareness and we can educate on it, hopefully we'll see some changes in those statistics. But yeah, otherwise, just making sure, again, like I said previously, following that comprehensive assessment, and you're going to take your Braden or your Norton number and you're going to incorporate it with those other factors that you're considering, including their skin tone.
So there is
So
guidance
true.
now. Yeah. And
Yeah. Sorry, as they say, don't look at the hole in the patient, look at the whole patient.
Right.
Yes.
Yeah.
Very good. Yes. So is this generally available, Jenna?
It is now, this resource. So it's available through all the NPIAP, wherever you get those resources. It's just the same tool, but it's a dark skin version of it. So that should be definitely widely disseminated through nursing staff for sure, so that they can, if they weren't taught it in nursing school, educate them now so we can do better.
And probably CNAs, who are often the first one to identify something.
Absolutely. Yeah.
Yeah, Susan, I wanted you to comment on something I heard you say when we were talking earlier about how infection control procedures now maybe interfere a bit with assessment of developing pressure injuries.
Right. I mean, I'm an older nurse, so I remember as a nursing assistant, we touched people, right? We touched their skin. We knew how it felt. We knew the temperature. We had bare skin contact. Certainly infection control and for good reason. It's extremely rare that we have skin on skin contact over bony prominences. When we think about it, especially, I can't remember the last time I did or saw someone touch a resident on their hips or bottom with a bare hand. So when we're talking about the evaluation of dark-skinned individuals or any individual, regardless of the color of their skin, detecting temperature differences or differences in firmness, which is what, I was taught. I think that may be a contributing factor, picking up on those early symptoms that we are not considering. And I agree with Jenna, that we definitely need to teach the nursing assistants to identify alterations in normal skin, regardless of the tone, because they are the ones who have the most contact.
Right. And I think what you're talking about now is particularly important in people with dark skin, where you don't see blanching or pink skin, an area. Yeah. You have to feel temperature changes or textural changes in the skin. And that's very difficult through gloves.
It's very difficult through gloves. Yeah.
So
panelists, we do have 10 minutes remaining.
All right. Well, we have so much more that we could cover. Let me ask you to look at, in particular, the role of leadership in preventing pressure injuries. This is about developing the right system. So let's talk about first, what's the role of the DON? Or does the DON have a role at all?
Absolutely. As the director of nursing, you're kind of where it starts. So making sure, number one, that you're reviewing and admitting residents to your facility that you have the ability to provide the care for. There are some instances in which you may get a referral to admit somebody into your facility, but do you have the resources and including the staff time to provide the care necessary for more clinically complex patients. So, and then making sure that when you do admit residents with wounds, they have the resources available and the education on how to provide that care. So that's on the director of nursing to make sure that all of those pieces are in place, and also making sure that there's transparency and expectations. So auditing and follow-up and re-education is critical in the role as director of nursing, to make sure that, and that includes, like Susan mentioned earlier, agency staff. If you've got agency staff coming into your buildings, you should have checklists and making sure that each time they come in, they should be updated with any policies and procedures that have changed in the facility.
Susan, anything else you want to add to director of nursing role? Like, and to what extent should the director of nursing be involved? How hands-on?
Well, depending on the size of the building, of course, and the number of wounds, but I would expect the director of nursing to be intimately familiar with every pressure injury in the building. There's no substitute for laying eyes on the resident, on the wound, observing dressing changes, or delegating that task to a nurse manager. You have to be present. You have to trust but verify that things are being completed. It's a challenge. There's no doubt about it. But yeah, we can provide the resources, do the education, but the director of nursing ultimately has to be on the floor, has to know their staff, has to know the residents, and they should be, like I said, intimately familiar with every pressure injury in the building.
And just to add one more thing, like thinking about the role of director of nursing and then your staff, just giving empowering your staff to discuss the problems and to bring the issues and challenges they're having to the director of nursing's attention, so that you have the ability to do better.
Okay. Let's move on to medical director. What is the role of the medical director?
Sure. As I was listening to the director of nursing or ADO and anyone who takes on, but really the key is, as what you all are taking, is the same thing, to implement, but to empower and educate at the same time. It's really hands-on. So I used to do weekly wound rounds with my director of nursing, ADON, and the educator. And we used to look at all the wounds and call up the wound doc if the wound doc was in town, or would do the weekly wounds also. So really looking at the patient, working with the patient and the staff, making sure we are implementing what we are saying, we are re-educating what is missed, and empowering the staff so they feel confident enough to come to you. Sometimes it's the CNAs who see the wound, but they are not able to communicate with their nurse, floor nurse. So the environment and the culture should be open enough that they can come and tell you that, look, this is what I see. So role of medical director is very crucial, but the medical directors should be equipped with that knowledge base of how to find the wound and what to do once you find it.
It sounds like you're nicely describing the collaborative approach that Susan referred to earlier between nursing and medicine, and probably other disciplines as well.
And communication with the families. It's so crucial and should be timely. Yes. With documentation. You really have to make sure you document it at the time, you document the risk factors, you communicate with the family members, because there's a lot of myth and misconceptions that are out there in public with Dr. Google and lawsuits that they would feel, oh, wow, should we just go for a lawsuit now? So connecting with them, that you care, you see it, is there, is so important as a medical director.
Right. And that's a really important note to almost end on, which is to come across as caring as well to the families. Let me give you each a brief moment to say, what are your parting thoughts? What do you want the takeaways from people today? And then we'll see if we have time for a couple of questions. Jenna, we'll start with you. What do you want people to take away?
So I guess my takeaways would be the importance of that comprehensive assessment with interventions associated and relevant to all factors of that assessment, and not just the Braden or the Norton number, with key interventions, specific resident-focused, person-centered interventions. And then I know we didn't get too much into the communication with the direct care staff piece of this topic, but the communication of all of those interventions to the staff that are actually providing the care. So making sure that CNAs are aware of those interventions that need to be completed.
Susan, what are your takeaways?
Well, I think if I had some advice, I would say examine your systems. Take a QAPI approach to your skin program within your facility and be honest about it. Put in place an action plan and start working. Ignoring issues will only create problems. And also make sure that your staff is educated and supported. Make sure they have the tools to do their job. Do they have the products, the education on the products? Do they have something as simple as enough pillows to position people in clean linens? Very important. Talk to the staff and find out, what do they need in order to do a good job. And then, as Jenna was mentioning, let's evaluate what we know about the evaluation and assessment of darker skinned individuals. And then keep your medical director and your physicians in the loop and have them document to support your program. And if you find that the challenges have become so great and you're not really sure where to go, if it's a smaller standalone building, I would recommend that you have an outside consultant possibly come in and assist you with it. We have a lot of limitations on our resources right now, especially in nursing. And so if it's a remote review or education, or if you need a consultant to come into the facility and assist the staff with all of that, I would highly recommend it. It's definitely an ounce of prevention.
Yeah, great. Thank you. Okay, quickly, Fatima, yes. What do you want people to take away?
Yeah, just 1 cent, like medical director has to be more of a servant leader, need to work in the trenches with the patients, with the people they're working in facilities, with families, really making them empowered, connecting with people, the staff, educating them, documenting in a timely manner. And if you don't know, then reach out. Post-acute long-term care society has a whole pool of educators. So if you don't know, reach out. But don't think that you assume that you know everything. But really hands-on medical director is something that helps everybody in the facility.
Yeah, it would be good if we all had that. We have 1 minute left, but let me just start with a couple of questions. And just so everybody knows, we will address all of your questions and send out the questions and our responses to those questions probably fairly shortly. You should be getting, or you should have already gotten a handout with links to other resources that might be useful. And for those of you who are wanting CEUs, please remember, fill out the evaluation when you get it and send that back in order to get the CEUs. So we'll try one question here. Do you recommend a facility having a nurse specifically assigned to oversee wounds prevention? If so, should they be part-time, full-time, and who do they report to?
I'll start. In an ideal world, the answer would be yes, they would be full-time, reporting to the director of nursing.
Okay. And that can be the educator also, if you can afford.
I would recommend that you have depth to your wound program. I don't believe that one individual should have total knowledge and control over your wound prevention and management program, because if that person leaves, there goes all the knowledge and your system is at risk for breaking down. I suggest that you keep, although you should have at least one person who is designated as responsible for managing it. I believe that
and ensuring that consistency. Sorry to interrupt.
Yeah, absolutely. It shouldn't be a secret. Everybody should understand. And if the wound care nurse doesn't happen to be in the building, if the wound care nurse has a sudden medical leave of absence, there should be more than one person who can step in and oversee that program. But as far as completing the treatments and that type of thing, it depends on each building. Sometimes the consistency of having a treatment nurse who can teach the other nurses how to do the treatments and oversee it is usually your best bet.
Okay, I think we are losing people because it's the end of the hour, which makes sense. Yeah. So just so everybody knows, we will be addressing all the rest of the questions in here and sending them out to people. So thank you again for attending the webinar. And thank you very much to my panelists. You've been great.
Thank you so much for having me.
Thank you.
Take care.
Okay.